Hello, my name is Gary Ulaner, and I am the James and Pamela Muzzy Endowed Chair of Molecular Imaging and Therapy at the Hoag Family Cancer Institute. Today I'd like to discuss with you molecular imaging of prostate-specific membrane antigen, or PSMA, targeted PET-CT, and how it can help patients with prostate cancer. Here are my disclosures. I also like to disclose that I teach molecular imaging starting at an early age. This is my son, Ilya, and my daughter, Annabelle, who are both experienced at helping me teach at molecular imaging conferences. This was, of course, before the COVID era. So here's a shot of the family currently and how they've adapted to living in Southern California. Let's talk about an important problem in medical oncology, in the treatment of cancer. The problem is current imaging modalities often have difficulty finding small tumors. It is estimated that many cancers can't be seen on standard imaging modalities such as CT scans until the tumor reaches about 1 centimeter in size. A tumor that's 1 centimeter in size is composed of more than 100 million cells. That's 100 million chances to become resistant to therapies, 100 million opportunities to spread. Now, molecular imaging can't decrease this to a single cell. However, with molecular imaging, we can find tumors as small as 1 millimeter or 2 millimeters, when these tumors may have 1/100th the amount of tumor cells that a CT scan can find tumors. Here's an example, and I know not everyone on the webcast is a radiologist, but this is a standard CT scan showing the heart, the lungs, the spine, and the question is, where is the tumor? Very difficult to find even for a trained radiologist. However, with the addition of molecular imaging, that big red spot in the breastbone can be found even by my children. This is molecular imaging detection of malignancy that is invisible on what would be considered other standard of care imaging modalities. This is how molecular imaging works. We can identify targets on individual cancer cells. Each cancer cell, prostate cancer, breast cancer, lung cancer, expresses its own unique targets. By designing binding agents that bind to those targets, like a key fitting into a lock, we can build agents that can detect individual types of cancer. We can then link to those binding agents radioisotopes, things that emit radiation. If the radioisotope emits a small amount of radiation, we can use it to visualize the tumor in a positron emission tomography scanner. If the radioisotope expresses a lot of radiation, we can even build keys that bind to cancer cells and emit enough radiation to kill the cancer cell. Today we'll be talking about an imaging agent, something that binds to, so the target is prostate-specific membrane antigen, or PSMA. PSMA is a molecule that sits in the membrane of prostate cancer cells. And by binding to that target, we can visualize prostate cancer cells far more sensitively than we can see them on other imaging modalities such as CT and bone scan. Now, there are many different PSMA-targeted imaging agents that are in development. There are 2 that have now been approved by the FDA. One, Gallium PSMA-11, is used at UCLA and UCSF. Another, which is known as DCF-PYL, or simply PYL, is what we use here at Hoag and at many other sites across the country. Here is the chemical structure of PyL, which is essentially this key that binds to the PSMA target and allows us to visualize prostate cancer cells. This is what these imaging agents look like when we see them, when radiologists see them in our scans. We can see the lacrimal glands, the salivary glands, the liver, the spleen, the small bowel, the kidneys, ureter, and bladder. These are areas that we expect to find PSMA, whether on PSMA 11 or with PyL. When we find activity in sites other than these expected areas, then we're suspicious for a PSMA-expressing tumor, such as prostate cancer. Hoag has sponsored a clinical trial, what we call a prospective clinical trial, of PyL in the evaluation of prostate cancer in two groups of patients. The first are patients with newly diagnosed prostate cancer that is considered high risk for spread of disease. The risk factors are a PSA greater than 10 or a Gleason score of 8 to 10. PSA is a marker in the blood which prostate cancer cells secrete, and high PSA levels may represent increased disease. Gleason score is a measure of the histology of the aggressiveness of an individual tumor. So tumors that fall into one or both of these categories are at higher risk for the tumor to have left the prostate and to have spread to other sites. The second group of patients that we ran our clinical trial in is patients with prostate cancer that has been previously treated but now is called biochemically recurrent. That means that PSA, that blood marker, has returned and gone up. This trial contained 184 patients, 92 patients in each of the two cohorts. And I summarize the results here. In cohort 1, approximately a quarter of the patients who underwent PyL demonstrated distant spread of disease that altered their management. And in cohort 2, more than half of the patients had biopsy-proven sites of recurrence that were detected by our PyL scan and were not seen by the standard of care CT and bone scan. Thus, a tremendous number of patients found benefit from the PyL PET scan and had their therapy changed for the better, having gone through this molecular imaging test. Let me show you a few examples of patients on this trial and how it improved their patient care. The first example is a 76-year-old man with newly diagnosed prostate cancer. His Gleason score was 8, so he qualified for the trial. Now, this patient was planned to undergo a prostatectomy. So he had a newly diagnosed prostate cancer. They were planning to remove his prostate. He underwent the PyL PET scan. And unfortunately, the PyL PET scan found sites of disease not only in lymph nodes in the pelvis, but also in bone. And those bony sites were then biopsy proven. Here's an example of the needle being placed in one site that was avid on the molecular imaging scan that unfortunately demonstrated a spread of the prostate cancer to the bone. So this indeed is bad news. This patient has more extensive disease, wider spread of disease than was appreciated prior to the PyL scan. But while this was bad news, it was really important news for this patient to have. Without this news, the patient would have had their prostate removed, would have undergone that extensive surgery and extensive recovery, possible side effects, including incontinence or impotence, and the prostatectomy would not have benefited this patient. Patients that have spread of their tumor to bone need to be treated with systemic therapies, because if you can imagine, they might remove the tumor that's within the prostate. But if you leave tumor behind in the bones, you have incompletely treated the tumor. So this patient was diverted from what would have been an inappropriate or futile surgery and changed to a more appropriate line of therapy for their extent of disease, saving this patient from undergoing surgery and moving the patient to a more successful form of therapy. Here's a similar example, another patient from the same clinical trial performed at Hoag. A 92-year-old man with newly diagnosed prostate cancer and a Gleason score of 8, suggesting he has a tumor that's likely to spread. He was going to undergo a prostatectomy for therapy, but the PYL PET scan found unfortunate uptake within bones, which was then biopsy proven. Here's the needle in the bone. This patient, again, would not have benefited from a prostatectomy, and luckily we were able to change the patient's therapy to another form of therapy more appropriate for their extent of disease. Screen's blank. Thank you. Here we go. Now let me show you some examples of patients that were in the second cohort, patients that were already treated and had biochemical recurrence or increasing PSA in their blood. This is a 65-year-old man with prostate cancer who had had a prostatectomy and then had salvage radiation to the pelvis. His PSA was rising. He underwent a CT scan and a bone scan, the standards of care for finding recurrent prostate cancer, but they were both negative. He underwent our PYL PET scan as part of our clinical trial. And the molecular imaging showed a focus of uptake which corresponded with a small lymph node in the pelvis. This was so small, again, it would be impossible for the CT scan to recognize this as a diseased lymph node. But the molecular imaging suggested that prostate cancer had recurred right here. This patient underwent biopsy. The needle shows the picture shows the needle within the lymph node. Biopsy proving that this was the site of the patient's recurrence. This patient underwent targeted radiation just to that area, just to that lymph node, and their PSA dramatically decreased, proving clinically that this was the site of clinical disease recurrence. So the PSA was able to define where the recurrent disease was when other, what are considered more standard clinical studies, more traditional clinical studies, the CT and bone scan, had failed. A similar case, a 72-year-old gentleman with prostate cancer, again, had been treated with prostatectomy and had radiation. His PSA was increasing. CT and bone scan both failed to find the site of recurrence. PYL PET scan was performed, and this PET scan showed, unfortunately, multiple sites of recurrence, one of which in the spine was biopsy proven to represent recurrent disease. Again, bad news that we're finding multiple sites of disease, but very important news to find so that the patient can go on to the appropriate systemic therapies to control the disease that had recurred before it gets worse. Here's another example of a gentleman with prostate cancer post-treatment of his original prostate cancer and an increasing PSA. the CT and bone scan were negative. This patient was planned to have additional radiation to the pelvis, presuming that the pelvis would be the most common site of recurrent disease. However, the PYL PET scan found unusual spread of disease to the abdominal wall, which was biopsy proven. Here the needle within the nodule as shown on an ultrasound image. So this patient went on to targeted therapy for the abdominal wall and systemic therapy as he had recurrent disease. And again, without the PYL PET scan, we would have never been able to localize his site of recurrent disease. This may be my final example from our 184 patient trial in which we helped dozens of patients. This is a 75-year-old man with prostate cancer following prostatectomy. Again, PSA was rising, so the risk of recurrence of disease was real. He had a CT and bone scan, which failed to show the site of the disease. But the molecular imaging PYL PET scan found a focus in the patient's penis, an unusual site, which was then confirmed by an MR imaging, and this was selectively resected, and at this point, the patient has no other known sites of metastatic prostate cancer. Now, this was done on a clinical trial, but I'm happy to say that this form of molecular imaging has recently been FDA approved. So we ran this trial at Hoag before it was generally available to the public, and it was the new imaging agent that we hoped was going to be very valuable for patients with prostate cancer. And that's exactly what it turned out to be, and it was subsequently approved by the FDA to be used now anywhere PYL can be produced and utilized. Hoag, it was the first hospital in Orange County to use PYL, and it is certainly the one with the most experience because we participated in the clinical trials that demonstrated the value of this agent. So this prostate-specific membrane antigen, or PSMA targeted PET imaging with an agent called PYL, has been proven to provide excellent sensitivity for detection of prostate cancer in the prostate and other sites, and even detect sites of disease that had been previously overlooked, as in the examples of the patients I showed with disease in the abdominal wall or the penis. Prospective clinical trials, one of which was run at Hoag, demonstrated that there is value for these patients in two groups. One with newly diagnosed prostate cancer at risk for distant metastases, and for patients with treated prostate cancer that now has biochemical recurrence, which means elevating PSA in the blood. And this, I've been referring to PYL as the new study and CT and bone scans as the standard of care. But I think now this molecular imaging with PSMA PET using PYL is the new standard of care. If you are a patient that falls into one of these two categories with prostate cancer, then PYL PET may be something that can be of value to you. And with that, I would say that this, I'd introduce you to our Molecular Imaging and Therapy Center here at Hoag, which performs not only the PYL PET scans, but also participates in multiple other clinical trial agents for patients with myeloma, breast cancer, lung cancer, melanoma. This is a site where we hope that Hoag will be participating in the development of more of these novel molecular imaging agents that help cancer patients everywhere. And if you have any questions, please contact our clinic coordinator, Beth Thompson, or feel free to call or email me. My name is Gary Ulaner. And I thank you very much for the opportunity to discuss molecular imaging with PYL PET and how it can help patients with prostate cancer. If I have an opportunity now, I will see if I can answer a few questions from the audience. The first is, how does PYL PSMA compare with Gallium-68 PSMA? Here is a comparison of direct images from these two scans. Now, it may take a little bit of a trained eye, but I think the images from the PYL, you'll recognize the images are sharper, they're clearer, they have what we call higher resolution. This comes from the physics of the agent. Fluorine-18 emits a positron with lower energy than Gallium-68. That lower energy positron travels a shorter distance before it annihilates with an electron, a little bit of physics, producing the photons that are found on our camera. Thus, you can get slightly better images with PYL than you do with a gallium agent. For clinical value, I think both of these agents are phenomenal, both gallium PSMA as well as fluorine-18 PYL. Does the slightly improved resolution of PYL translate to better clinical outcomes for patients? That has not yet been demonstrated, but it is certainly no worse. Another question. What are possible side effects of PYL PET scan, and is it covered by Medicare? These are diagnostic imaging agents, not therapies. Therapies can have significant side effects, but these imaging studies virtually have no side effect. When you have one of these scans performed, an IV is placed within a vein, usually within the arm, so the placement of an intravenous catheter can hurt or cause some bleeding. The agent is administered, and as most people feel nothing with the agent. A tiny number of patients say they have rare side effects like temporary alterations in their sensation of taste, or pain at the site of the administration. I imagine that pain is mostly from the IV, not from the agent, and the sensation of taste changes are always temporary. So in effect, the scan itself has virtually no side effects whatsoever. The therapies, of course, that are then used in order to treat a cancer often have side effects because benefits do not come without costs. Is it covered by Medicare insurance? So the PYL is now FDA approved and is covered by Medicare. It is also covered by most private insurers, but remember, it is covered for the appropriate indications. The indications that are defined are here. High risk initially diagnosed prostate cancer. So if you have a newly diagnosed prostate cancer that isn't considered high risk, that is not an indication for PYL. Because if you have a low risk prostate cancer, it is highly unlikely that your tumor has spread, and therefore you don't want to go looking for something that doesn't exist. And second, for patients who have treated prostate cancer, biochemically recurrent prostate cancer. So there are other scenarios where these agents are under investigation. For example, patients who have known widespread metastatic disease to help determine whether a tumor is responding to treatment or not. But that is not one of the two currently FDA-approved indications for the use of the agent. So often, whether it's covered by insurance is going to be determined by, are you within one of these two appropriate groups that fall into the FDA-defined label for its use? Does PYL have any application to theranostics? Outstanding question. Theranostics is the combination of therapy and diagnostics. In this case, the PYL is the diagnostic component of PSMA-targeted imaging and therapy. We can visualize tumor that contains PSMA, and then there are other agents which attack the tumor to treat the cancer. As we said in this diagram, you can imagine this is the binding agent, binds to the PSMA, and we have fluorine-18, which is a low-energy emitting isotope. If we have another similar key that also binds to PSMA, but emits high energy, like a beta or an alpha particle, then you can kill the cancer cell. That's the therapy side of theranostics. Hoag has 1 and soon 2 PSMA-targeted therapy trials open for patients who indeed are found to have PSMA-targeted metastatic tumors for consideration for PSMA-targeted therapy. So this is the imaging agent. Theranostics is both an imaging and a therapy agent. This imaging agent is now FDA approved. Therapy agents are not FDA approved yet. They're only available on clinical trials. And again, Hoag has 1 of them open and soon to open a second. Would liquid biopsy find tumors as small as PYL? You will have to forgive me. I am not an expert in liquid biopsies, which are finding molecules in the blood, small quantities of molecules within the blood that help find tumors. But at this time, I will say that there are no liquid biopsy procedures that are FDA approved, and PYL is FDA approved for finding small prostate tumors in the 2 cohorts of patients that I described. Is there similar scan technology for other cancers? Outstanding question. This paradigm is the basis of what I hope is going to be imaging and therapy for virtually every form of cancer. Right now, in addition to PSMA-targeted imaging, we have somatostatin receptor-targeted imaging for patients with neuroendocrine tumors and somatostatin-targeted therapy for patients with neuroendocrine tumors. Those are both FDA approved. We also have estrogen receptor-targeted imaging, which was recently FDA approved for patients with estrogen receptor-positive breast cancer. Hoag participated in clinical trials of that estrogen receptor-targeted agent, so we have extensive experience with it, and we have ongoing clinical trials of estrogen receptor targeting therapy as well. In addition, Hoag has ongoing trials in targeting CD38 for patients with myeloma and CD8 for patients who are undergoing immunotherapy, and there is a large and growing number of clinical trials in this field. How high does PSA need to be for PYL to be effective? Outstanding question. There is no one correct answer. If we look at the definitions, for patients, this clinical trial was for patients after prostatectomy whose PSA rose above 0.2 nanograms per ml, and after radiation, the PSA was greater than 2.0 nanograms per ml. There's no one answer for when a PSA is going to be high enough for a PYL to be valuable. But in general, I use this guideline. When the PSA, recurrent PSA in the biochemical recurrence group, when the PSA is about 0.5, you have about a 50% chance of finding a lesion on PYL that is missed on CT and bone scan. So if you're at that 0.5 level, I think there's a good chance PyL can help. If you're higher than that value, there's an even better chance that PyL will help. When you're lower than 0.5, the chance that the PyL scan will be positive falls off. But still, there is value. Because if you can find the tumor at 0.2 or 0.3 and successfully treat it, then you get rid of it before it grows to an extent where it can cause problems. So for our patients, now that the PyL is FDA approved, I use this as my guideline. If you have a PSA of greater than 0.2, then there is a chance that the PyL will be valuable for you. And that chance grows the higher the PSA value is. I just had an MR on Friday prior to my upcoming biopsy. How does this compare? Well, these are two very different imaging modalities. MR is an anatomic modality. The PyL is a functional modality. MRs are usually of specific areas of the body. So for example, it's not included in the question, but I presume this means I had an MR of my prostate. So MRs of the prostate are very good for finding disease and localizing disease in the prostate. But it doesn't evaluate anywhere else in the body. The PyL scan gives you an evaluation head to leg. So it can show you a breadth of disease that is not appreciated on a single MR scan. In many instances, you may have to have multiple forms of imaging studies, such as a PyL PET with an MR of the prostate or other local sites that are suspicious for disease, in order to get optimal imaging in any individual patient. Are there any other questions? Then great, we're right on time, about 30 minutes in. I thank everyone for the opportunity to hear our presentation on PSMA-targeted PET with PyL. Again, Hoag was the first hospital in Orange County to utilize PSMA-targeted imaging, and we are by far the one with the greatest expertise in its use. We hope we'll be able to help as many patients with prostate cancer with PSMA-targeted imaging as possible. And as a reminder, this is the tip of the iceberg. Molecular imaging is going to play a prominent role, if not already in the near future, for a wide number of malignancies. My name is Gary Ulaner. Thank you so much for your attention.